been 3 minutes. I think we're good to get started. Good evening, everyone, and thank you for joining our men's health webinar. We'll start with a few housekeeping items, and then I'll introduce tonight's speakers. First, your participation in tonight's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speakers. If you wish to ask a question, please type it in the chat box at the lower part of your screen. We will have a Q&A portion at the end of the presentation to address all these questions. Please don't be shy. Our presentation tonight will last for approximately 1 hour. It will be presented by Dr. Laurence Levine and Dr. Eric Kirshenbaum of UroPartners. Dr. Levine attended medical school at the University of Colorado Medical School in Denver. Then after completing his general surgery internship at Tufts in Boston, he went on to reach chief resident at the American Hospital of Paris, then completed Harvard's program of urology in Boston. Dr. Levine is world-renowned for the treatment of both erectile dysfunction and Peyronie's disease. In addition to general urology, his primary focus over the past 25 years has been in the fields of andrology and reconstructive urology, including disorders of male sexual function, male infertility, urinary incontinence, congenital deformities, and deformities of the penis caused by Peyronie's disease. Dr. Eric Kirshenbaum completed his medical education at the University of Illinois in Chicago, followed by a residency in urology at Loyola University Medical Center, and then a fellowship in men's health and reconstructive urology at Loyola University Medical Center, under the mentorship of Dr. Chris Gonzalez and Dr. Kevin McBarry. He specializes in men's health and reconstructive urology with an emphasis on urethral stricture disease, erectile dysfunction, male incontinence, prosthetic surgery, BPH, laser surgery, urologic cancers, telemedicine, and robotic surgery. He has dedicated his career to restoring functions lost with aging, trauma, and cancer treatments. Again, thank you all for joining us tonight. And without further ado, I'll turn it over to Dr. Levine to get us started.
Thank you, Annie. I want to also thank Boston Scientific for helping to sponsor this and make the whole process come together. I know that quite a few people did sign up, and hopefully we've got a lot of them on board right now. We have done these seminars before, and I'm sure we'll do more in the future. I think it's just useful to educate as many people as possible about these things, and particularly if they're interested in it, we can help them understand the nature of the problem and maybe offer some answers and solutions to those problems. Dr. Kirshenbaum and I are both part of UroPartners. There are many UroPartners doctors, as you may know, in the system, and many of them specialize in this area. At the end of my talk, I'll show a little list of the doctors that may be your doctor that you might want to talk to about these things. But of course, Dr. Kirshenbaum and I will be available to you too, should you have questions or want to get a consultation. My topic to start is going to be to talk about, just get this to work here now. Talk about erectile dysfunction. And we'll talk about what it is, who has it, and what causes it, and look at certain patient populations that may be at higher risk. I'll also say that our goal is to wrap it up close to 7 o'clock as we can, because I know some of you may be hockey fans, and we got the final game of the NHL coming up, starting at least around 7 o'clock. But, in the beginning, there's a bunch of, nonsense stuff anyhow, so you stay on board so you can learn it all and ask any questions you may have. So what is ED? Well, some years ago, a panel got together and defined it as the persistent inability to achieve or maintain an erection firm enough to engage in sexual intercourse. And it is a rather prevalent problem. In fact, about 20% of men over the age of 20 will experience ED sometime in the lifetime, and oftentimes once it occurs, it tends to stay with you, particularly in the older man. As you can see also that about 50% of men over the age of 40 have some degree of ED, meaning maybe a little difficulty obtaining erection, or as things get worse, difficulty maintaining erection, and then maybe not being able to obtain or maintain the erection. And this ultimately affects a large population of men in the United States, estimated to be around 39 million. Now, the erectile process is actually pretty simple. I think of it as what I call a neurovascular event. So something affects our brain. The arousal system is turned on because otherwise we're not having erections except when we're in seventh and eighth grade and have those unwanted erections at that time. But as an adult, we get control over it. And arousal is what triggers the nerves in the brain to send messages to the penis where blood vessels respond by relaxing. And by dilating those veins, we get more flow into the penis very rapidly. And as the pressure builds up, the penis becomes progressively more erect. As a result of that erect process, the veins in the penis get sort of stopped off. I'm not sure if you can see my hand here, but if you imagine this is the wall internally, the veins are piercing through. And as the pressure builds up inside, like a flap valve, those veins get shut off. And that's called venous trapping. The problem is when you don't have venous trapping, you have venous leakage, and then the blood is not staying in the penis. We used to think that erectile dysfunction was, primarily in your head. Go on a vacation, you'll be fine. You're under too much stress. And of course, that can certainly be part of it. And secondarily, for men who have erectile dysfunction, that can certainly cause a lot of distress because of fear of failure, so-called performance anxiety, which is a very real thing. But we also found that the great majority of the time, ED is a structural problem, an organic one. And the top physical causes, as you can see on the left there, are diabetes, high blood pressure, elevated cholesterol, lipids, and smoking. I call them the erection busters. And the longer you have those kinds of problems or engaging in that kind of activity like smoking, the more likely you're going to do damage to those vessels. I call it putting the foot on the accelerator of natural aging, because with natural aging, we'll have blood vessel changes. But if you have diabetes, high blood pressure, elevated lipids, and smoking, you're really going to step on the gas and make that problem more likely to happen sooner. ED can also be the result of prostate cancer treatment or diabetes, as we'll talk about later, but it can be a precursor to heart disease because the blood vessels of the penis are so small, about a third the size of coronary arteries. We oftentimes can find that ED precedes cardiac disease, heart disease. So let's talk about ED and the diabetic male. Well, according to an old census now, 2012, about 15 plus million men in the United States do have diabetes. And when ED occurs, it tends to occur 10 to 15 years earlier than men who don't have diabetes. It also turns out that men who have diabetes tend to be less responsive to oral medications such as Viagra, Cialis, that whole class of drugs. And 1 in 2 men with diabetes have sexual problems. In fact, by the time you're 7 years into the diagnosis of diabetes, most men with diabetes will start developing problems with ED. And the worse that their diabetes is controlled, the more severe is their erectile dysfunction. And also we find that in my own experience, and I suspect with Dr. Kirshenbaum, you'll have men come in with a complaint of erectile dysfunction and you do a simple urine analysis or a blood test looking for blood glucose levels, sugar in the blood, and we'll find and make the diagnosis of diabetes. In fact, today I operated on a young man, actually just turned 50, who I diagnosed with ED about 10 years ago. And we ended up actually putting a penile prosthesis in today. So good example of that. The diabetes can also damage nerves. We call it microneuro and microvascular injury. And those tissues are involved in the whole process that we talked about before with respect to getting an erection. So up to 70% of men with diabetes will have nerve damage. So those nerves that are trying to conduct that information to trigger the vasorelaxation to get the erection may be injured. And the lining of the blood vessels, that's called the endothelium, a very biologically active area in the body, the lining of blood vessels. If that gets damaged, which happens with diabetes, the blood vessels, even if they're getting a message, can't dilate properly. And so that will interfere with blood flow. And of course, the oral medications that we use rely upon nerves to get the stimulation to go and the endothelium, the lining of the blood vessels, to respond. And so therefore, diabetics tend to be less responsive to those pills like Viagra, Cialis, and the rest. So factors which may increase ED in men with diabetes, well, the older you are, you might have other factors that might be contributing, just age-related changes, but then the diabetes contributes to it as well. The longer you have diabetes, as I said before, the poorer that you control the diabetes can certainly contribute. If you've got microvascular complications, and if you already have cardiovascular disease, we know that if the bigger blood vessels in the heart are compromised, we know for sure the tiny 1 millimeter blood vessels in the penis are likely involved as well. What about ED and heart disease? Well, it turns out that ED is now recognized as a warning sign of more serious issues, such as an indicator of silent coronary artery disease. The coronary arteries, again, are the vessels that supply the heart. And if those blood vessels get compromised, it's likely that the blood vessels in the penis are already compromised. And in fact, studies have shown that ED oftentimes precedes coronary symptoms like chest pain and things of that sort in about 70% of patients who ultimately develop coronary disease. And as you can see in the cartoons there, symptoms of heart disease oftentimes develop within 2 to 3 years of ED. Now, this isn't in all men with ED, but certainly in men who are in their 50s, 60s, and 70s who now start developing ED, it may be telling us that they've got generalized vascular disease, and the ticker, the heart, may be next on the list to start having some symptoms. So how do we reduce our risk? Well, there are some things that we can do to improve your heart health. And there are healthy lifestyle choices noted here, such as diet. You know, don't eat a fatty, greasy, fast food diet. That's certainly high in all the bad things that you can do for your body. Exercise and physical activity on a regular basis is a wonderful thing. Just going out, as shown in this picture here, taking your partner by the hand and going out for a vigorous walk. If you start developing a little bit of a sweat, that means you've got your heart rate up, and that's good for blood flow throughout the body. So doing a little exercise every day like this is a good thing. Losing some weight and stopping smoking certainly are also critical to reducing the likelihood of accelerated vascular disease and injury. What about prostate cancer treatment and erectile dysfunction? Well, we know that the nerves, as I talked about, run along so we call it the posterior lateral aspect of the prostate. So they come in from underneath and on the side. And they're really tiny little fibers. So it's not like they're visible nerves that we can see well at the time of surgery, but we kind of know where they are to try to protect them as best we can. But they get injured quite easily. There are also some vessels that run in this area that supply the prostate that might get injured at the time of radiation. But both of these things, surgery and radiation, can possibly compromise future erections. And in fact, it's been estimated that up to 75% of men who undergo treatment for prostate cancer, whether it be surgery or radiation, may develop some degree of ED. It may not be complete erectile dysfunction, but it may be diminished ability to get the quality erection they had before they started treatment. For surgery, the injury is immediate. The nerves, let's say, are severed, and as a result, the likelihood of having them heal over time is low. And as suggested here, that about 50% of men at 1 year will have some degree of ED, even with the robotic prostatectomy techniques. Radiation therapy tends to be a little bit slower. It may be 1 to 3 years where the injury caused by radiation causes progressive damage to the blood vessels, supporting the blood supply to the penis. And then 50% of men, as we get out to 5 to 7 years after radiation, will develop ED symptoms. Um, so the treatment of prostate cancer patients tend to be older. So they tend, in general, have a higher risk. We know that the older we get, the more vascular changes that can occur naturally, so to speak, just by age. But then if we had insult upon injury here with either surgery or radiation, we might be more apt to have erectile dysfunction. And surgery, as I suggested before, can damage the cavernosal nerves running along that back surface. So if those nerves are just dinged, if you just whack a nerve, luckily, those nerves can recover over time. It may take several months. It may take the better part of a year. But if you have no recovery of erections after a year, trying drugs like Cialis and Viagra, nothing's happening, I think it's unlikely you're going to have rigidity adequate for sexual activity even if you wait another year. On the other hand, if we know that the nerves were taken at the time of surgery because they had to be, they may have been in the way, or the type of cancer that was there needed to be sacrifice those nerves, the likelihood of those nerves coming back is virtually zero, and so it's unlikely you'll recover erections. And in fact, sadly, some recent published Medicare surveys, when looking at what's the likelihood that you're going to have erections like you had before you had surgery in particular, only 10% recover rigidity similar to what they had preoperatively. And that's with the best of hands. It's just the nature of the beast, I'm afraid. And of course, the other thing that men don't like is losing length in their penis. And about 70% will lose 1 to 2 inches of length. And that can be, needless to say, devastating. Nobody likes that. There's some tricks that we can do using vacuum devices, using oral medications to try to induce some blood flow in the area to protect it. But we use the old expression, if you don't use it, you lose it. And what's happening here is if you're not getting erections, we're not bringing nourishing blood into the penis. And then what happens instead is collagen, the stuff of scar tissue, infiltrates into that tissue and reduces the elasticity of the penis, resulting in that length loss. Rehabilitation has been offered, and there's been a ton of research on how to rehabilitate maybe the nerves and preserve the function of the penis. But unfortunately, there's no clear, reliable approach that can be used. I have my most aggressive program, which I list here. I start patients on medications like a nightly Cialis or Viagra before bed, beginning a couple weeks before they have either radiation or surgery, and continue that for maybe even up to a year. And then every week, they might take 1 to 2 full doses with stimulation to see, hey, am I having any response here, so they can monitor their own response. We can have them use a vacuum device daily. This is primarily to preserve length. Again, that process of having the infiltration of scar tissue, we can help prevent that, prevent the if you don't lose it, you lose it problem. And then injection therapy that many of you may have heard about, which is a treatment for ED, can also be used as a form of rehab where you're giving yourself an injection every 2 to 3 times per week with or without sexual activity, again, to maintain the activity of blood flow in the penis. So who can treat this problem? Well, certainly your primary care physician is capable of initiating therapy primarily with oral medications. But if those aren't working, typically a urologist will take over, can consider some other more aggressive approaches. And then the final option would be the prosthetic urologists like Dr. Kirshenbaum and myself, who are specially trained in how to do the surgery to address this problem very successfully. So let's spend the last bit of our time here talking about some of the treatment options. As you can see, I've listed them pretty much across the board. We'll start with oral medications, and that's, again, the Viagra, the Cialis, Levitra, Stendra. Those are the four of those drugs that are currently on the market. How do they work? Well, basically, they increase blood flow to the penis because when we get sexually aroused, the brain sends messages that release a chemical there that causes the blood vessels to dilate. We make our own chemical in that neighborhood that breaks down that good chemical. And what the Viagra, Cialis type drugs do is they prevent the breakdown. So more of that chemical, when you're being aroused, is being released and hangs around to stimulate the blood vessels. So sexual stimulation is necessary. And that should be taken, these drugs should be taken 1 to 2 hours before anticipated sexual activity. The Cialis has a much longer duration of activity, whereas Viagra is the 4 to 8 hour duration of action. But it should not be taken more than once per day. And in particular, Viagra can be affected by food. All of them can be affected by food because if you have a big tummy full of food there, the drug will the drug, and you take the drug at the same time, it'll get stuck in the stomach, and because the stomach doesn't tend to empty as quickly to get the drug into the bloodstream. About up to 80% of men will respond to these oral medications. But men with more advanced erectile dysfunction, saying after prostate surgery or advanced diabetics, are less likely to respond because of the vascular and nerve injury. Most common side effects of oral medications: headache, facial flushing, stuffy nose, maybe some upset stomach or back pain. That has nothing to do with anything bad. These drugs are not bad for your heart. They do not cause heart attacks and things of that sort. They actually cause increased blood flow to the heart. So safe in that regard. But there are some cautions. You need to know whether your heart can tolerate the exercise of sexual activity. It's not very much exercise. It would be the equivalent of maybe walking up a flight or two of stairs. So if you can walk up a flight of stairs without chest pain or shortness of breath, well, then you're a candidate to try these medications. A lot of men, particularly when we get older, have some prostate issues and may take medicines we call alpha blockers. So that would be like Flomax or Uroxetrol or Alfuzosin. Generally, if you're starting on those drugs for your prostate, we don't want to take the Viagra or Cialis at the same time. We want the body to get used to the alpha blocker before maybe you take the medication for your erection. And if you're on any medication that's a nitrate, such as nitroglycerin tablets or Imdur, there's a variety of them. This is an absolute contraindication to take this whole group of oral medications for ED called PDE5 inhibitors. Viagra, Cialis is what I'm talking about here, because the combination of a nitrate with, say, Viagra can cause catastrophic drop of blood pressure. So absolutely cannot take it. So before you start asking for this medication, you need to make sure that you talk to your doctor about any cardiac issues, high or low blood pressure, any kidney or liver problems, so that we can treat accordingly. What about vacuum devices? I'm not sure many of you know about this. This is one of the oldest treatments for ED. It actually was introduced in the early 1900s. Pretty simple. We're taking a hollow plastic tube, kind of like shown on the cartoon on the right there, and it's placed over the penis. And then there are now hand and battery operated pumps that will with vacuum, pull the blood up into the penis. And then once an adequate erection is achieved, a constriction band is applied around the base of the penis to maintain the blood there. It has limited, I think, success in my hands, or at least very few of my patients appear to stick with it. Reports have suggested up to 80% of patients can get a good result, but not many patients tend to stick with it. And the reasons for that is because it can cause blocked ejaculation. The vacuuming can cause some bruising. There's no danger in that, just it's unattractive. There can be some discomfort. And you can even have some numbness or coldness because of the constriction band to the base is restricting blood flow. So the most common reasons then for discontinuation of a vacuum is that it just doesn't give us a good enough erection or doesn't last long enough for success. It certainly is cumbersome. That's probably the most common reason I hear patients not wanting to do it. It can cause that bruising, and it can result in a lack of spontaneity. One of my first papers I wrote as a young attending at University of Chicago was on vacuum devices, and we found that probably the best population was an older man with his maybe older wife. They were, well-established relationship and just wanted to be able to engage in sexual activity, but weren't candidates or interested in some of the more advanced treatments. There's injection therapy. This was actually introduced back in the mid-1980s, about when I started practice, actually. And what it does is it allows a man to inject himself into the side of the penis with a drug which bypasses the brain and directly stimulates the blood vessels, those tiny blood vessels, to dilate. So it creates actually a fairly natural erection within 5 to 20 minutes after injection. And about 60% of patients will find that it works. It tends to work in some men who fail oral therapy. It's the next step up the treatment ladder. But unfortunately, in one study shown here, and in a study I did also back in the late 1980s, very few of the men who get a really good result stick with it more than a year. Because they just find the whole process of sticking a needle down there every time they want to have sex to be somewhat noxious and unnatural. So the most common side effects are pain. You can get scar tissue if you're not doing it properly. An erection that doesn't go down, which is a very dangerous process that might result in having to go to the emergency room. But in those men who do choose to use injection therapy, and I've treated well over a couple, 3,000 men now with injection therapy, some of whom are been on injections now for 20 plus years. They like it, and it does what they want. But they have to know that if the erection lasts longer than 2 hours, they need to drop down their dose, and certainly at 4 hours, they're on their way to the emergency room. What are the most common reasons for discontinuation? As I said, dislike of injections, pain, or just unsatisfactory erections. Let's talk now about probably the ultimate solution, which would be the penile implant. How does that work? Well, basically, you have a pair of cylinders which are placed inside the penis, a pump which is placed inside the scrotum adjacent to the testicles. You're not squeezing your testicles when you want to get the device to work. And then there's a reservoir, an invisible reservoir, which is placed behind the stomach muscles. And all of this can be done through I'm not sure if you can see my fingers here, but through an opening in the scrotal sac. That's one approach that I use. That's usually about 1.5 inches up into the reservoir. So it is an internal self-contained hydraulic system. How effective is it? Well, upwards of 98% of patients report the quality of their erections to be satisfactory to excellent. And in one study, about 94% of the men who had their device in for at least 7 years found that they were still in use and free of revision. Most common side effects, postoperative pain, that tends to go away and it's very variable, but typically a week or two of discomfort is noted, and then it would completely disappear. You don't even know it's there. It'd be like wearing my glasses here. I don't think about my glasses on my face anymore. I'm just used to it, or wearing a ring. There could be mechanical malfunction we'll talk about in a moment, and infection would be the most dreaded, I think, complication. Boston Scientific actually has an array of different implants, starting with the one on the left, the so-called Spectra or Tactra device. It's a concealable, malleable device. It's always firm, but can be positioned up or down. They rarely, if ever, fail But most men, I think, these days want the last one on the right, which is the inflatable device, because it's much more natural. You're walking around flaccid and normal. Although men may be thinking about sex all the time, probably it's only a few percent of their daylight hours that they may really want to be erect. So why not have a penis that looks normal in the flaccid condition? That's what these inflatable devices can do. The middle one, the Ambicore, has been recently discontinued. So how does it work? Well, you want to squeeze the pump, which is located in the scrotum. Fluid moves to create the erection and deflation here. Now I'm gonna think I should gotta have well, I have a video here. It was done by a colleague of mine out in California, Dr. Cartman, that shows what these devices look like. This is a man who had one implanted, and it shows him inflating it and deflating it. And you can see how relatively easy it is. It's running here. Huh. Well, what's going on? Let's see if we get it to work, folks. I'm sorry about that. We had it.
Are you able to fast forward a little bit? Is it frozen or is it moving? Just if you click
Oh,
like in the middle of the video
yeah, because I've
on the
tried.
bar.
Yeah, too bad.
There we go. Maybe it's just a really long intro. Let's see if that works
No,
now.
no, it's just not moving, I'm afraid.
But if you press play one more time, what if it's your internet connection? If anything, Dr. Levine, I can share a link to this video in the chat for the audience.
Okay. Right. Well, I apologize about that, folks. But I'm not sure if you can see on the screen. Oh, here. Well, I'm just going to kind of roll through real slowly. You can see here he's actually using his hand to squeeze the pump, which is in the scrotal sac. He's stabilizing it with the left hand. Pump, 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 pump. And now you can see he's got a pretty good erection here. And it will stay like that until he brings it down. See, he's got a wonderful erectile angle there, good support of the head. And now we're going to bring it down, and you hit a button that's built into the pump. You can see it there with his left index finger. He's compressing it, and the penis automatically goes down. But if we really want to get everything out, we kind of give it the penis a squeeze, or as he's doing, pushing it down here, and it makes it for a nice erection. All right. And now it's working somehow. How about that? So, what's the data on penile implants? Well, 97% of patients would recommend a penile implant to others. 98% of patients reported their erection to be satisfactory to excellent. But I think this is a particularly important study. 96% of partners reported that the sexual activity they had with their male partner was satisfactory to excellent. I also published a paper several years ago asking the female partners of men who had a penile prosthesis about how natural did the penis look in the flaccid condition, in the erect condition, and most importantly, how natural did it feel to them during intercourse when a penile prosthesis was being used, and the scores were high across the board. So this is a very effective way to be able to create a very usable erection on demand. So basically, the benefits of a penile implant are shown here. It's designed as a permanent solution. It's one and done. It's spontaneous, so that if you're interested in having sexual activity, you activate the device. It takes a minute, if that long, to inflate. It's not restricted to any age group. It is an outpatient procedure. Typically, the two I did today were outpatient procedures performed at our surgery center. Typically an hour, and you go home. Erection can last as long as you desire. So if you want to have intercourse for a prolonged period of time, that's up to you. And it's entirely contained within the body. There's no external pumps or apparatus. You could walk naked on the beach and no one's going to know you have it. And there's also, as I suggested, high patient and partner satisfaction. But I think also important to recognize is it does not interfere with urination, ejaculation, sensation, or orgasm. So when you are in the mood to be able to have relations, you can, and nothing else changes. All this device is doing is providing rigidity on demand. They've been around for 50 years. The 1970s is when they first came out. So they've made improvements in making them more reliable and safe. And nearly 500,000 patients have had penile implants placed with this Boston Scientific device. We should realize that there are risks with any surgery, and these risks would include potentially mechanical failure. I think the most recent data would suggest in 10 years, about 20% of men might have a mechanical failure. You flip that around, 80% of men in 10 years still have a functional device. Pain typically is short-term. In time, you don't even know it's there. An infection, as I say, is the most dreaded complication. My personal infection rate with over 4,000 devices placed now with all different types of patients is around 1%. So if it gets infected, it does have to be removed, but the infection rates are quite low. As far as some of the new age approaches that are out there, you may have heard of shock waves or PRP, amniotic factors, or stem cells. Very little data to show that these the alternative approaches are effective. They're usually out of pocket and expensive to pay for. These low intensity shock waves are probably the most effective approach, but the population that it seems to help are young men who tend to respond well to Viagra or Cialis, but just simply don't want to take the pills. So in summary, erectile dysfunction is a common problem. It may be associated with other conditions, diabetes, heart disease, of course, prostate cancer therapy. There are a variety of treatment options. Penile implants can provide a permanent solution. It's certainly the last option and oftentimes the best option. Some of the happiest campers I have in my practice are men who have had a penile implant. Certainly talk to your partner about this, see if it makes sense in terms of your relationship to go this route. And you can certainly talk to your ED specialist. Here's that list I was talking about earlier. You can see on the left, we have penile implant specialists who are within the UroPartners system, all the way down the line. And then we also have urinary sphincter, artificial urinary sphincter specialists within our group as well. And Dr. Kirshenbaum will be talking about that in a moment. So I want to thank you for your attention. And I'm going to stop the share on this so Dr. Kirshenbaum can load his slides. Thank you again. And I look forward to any questions. We can talk about them later.
All right. Thank you, Dr. Levine. Can you hear me?
Yes.
All right. So let me share my slides. All right. And you can see the screen?
Yes.
All right. Perfect. All right. So we're going to transition a little bit from erectile dysfunction to urinary incontinence. This is probably my third or fourth time hearing Dr. Levine's talk, and I still pick up little tidbits. Yeah, thanks for your talk. All right, so here's just a little bit about myself. I am in the northern suburbs of Chicago and in actually southern Wisconsin, go all the way up to Pleasant Prairie. And yeah, we'll get into urinary incontinence. So we'll start by talking about what stress urinary incontinence is and how common it is. So there's two types of incontinence that people come to me for and come to all urologists for. There's stress urinary incontinence, and then there's overactive bladder or urgency incontinence. And what I'm going to focus on today is the stress urinary incontinence, where there is a deficiency in the sphincter that holds back urine. And what happens is, because of the deficient sphincter, patients have dribbling of urine or a full flow of urine with things that increase your abdominal pressure, like laughing, lifting, bending, running, anything active that requires a sphincter to hold back urine. It is a very common problem with worldwide 500,000 men suffering from stress urinary incontinence. And patients that come to me with this issue, it's not just that they're kind of leaking urine and they're a little bit bothered by their wet underwear, it's uncomfortable. It really impacts their entire life. It impacts their mental health. It impacts their ability to function socially, to go out, to interact with friends. There's a ton of social anxiety associated with stress incontinence. People become depressed because of the impact of the leakage has on their day-to-day. They're psychologically disturbed, they're emotionally disturbed, and they often feel socially isolated. In addition to the emotional and psychological component, there's a physical component to it. It's very uncomfortable to walk around with kind of urine-soaked underwear or urine-soaked pads, and it really can take a physical toll on patient's body. So the one specific population that's most impacted by stress incontinence is the prostate cancer survivor. So there's just like erectile dysfunction, there's a strong correlation between the development of incontinence and prostate cancer treatment, whether that be surgery, robotic or open, or radiation therapy. I tell all my robotic prostatectomy patients that they can expect to leak immediately after their prostate cancer treatment. Luckily, only 9 to 16% of men still have bothersome incontinence at 1 year. And that's really who we focus on in kind of getting them back to where they were and restoring that function. Now, while incontinence is the largest population is definitely the prostate cancer survivor, I also see patients who have neurologic disorders, who develop stress incontinence, patients who've had enlarged prostate surgery, who've unfortunately developed incontinence, patients who've had radiation, and patients who've had trauma to the area that's impacted their ability to hold back and store urine. So you'll remember this graphic from Dr. Levine's, but some of the same reasons why patients develop erectile dysfunction, they also will develop the incontinence. There's a large amount of prostatectomies that are performed each year, nearly 70,000. And just like for erectile dysfunction, the nerves that supply the sphincter and then the sphincter themselves can get damaged in any sort of prostate cancer treatment. And as you can see, what is a prostatectomy? For those who don't know, a prostatectomy is removal of the prostate and then reattaching the urethra to the bladder. And in that process, you can damage the nerves, but also in reconnecting everything and cutting everything, you can damage the sphincters that hold back urine. So how do patients cope with this really gigantic lifestyle change that happens after either enlarged prostate treatment or prostate cancer treatment? Patients often start by just changing their behaviors. They reduce their fluid intake. They're running to the bathroom every 30 to 45 minutes just so they don't have a full bladder and therefore a full pad. I send a lot of patients to pelvic floor physical therapy, which can have some benefit to regain those muscles and regain those nerve connections. A lot of you may have heard of Kegel exercises where you squeeze the pelvic floor and really build up that muscle. And then there's biofeedback where you work with a therapist to kind of strengthen those muscles and have a better connection between the brain and the pelvic floor to hold back urine. Inevitably, those patients who are wet will also have means to not be so wet. And so that's where the pads and the diapers come in. The example that I tend to use with a lot of my patients is when you go on vacation, these patients suffer for so long and they have to bring suitcases full of pads or diapers just to get through a single vacation. There's also catheters where patients can insert an indwelling catheter or something called a condom catheter to catch the urine and have it drain into a bag as a means to cope with the amount of leakage. And then there's a penile clamp, which is what it sounds like, a clamp that clamps down the urethra and holds back urine. Most patients that come in with a penile clamp, I haven't met a patient who has a penile clamp that loves wearing it. It could be cumbersome, it could be uncomfortable, and not the long-term solution that most guys are looking for. In addition to just the discomfort of having to wear pads or diapers, it really can be a huge expense to patients. If, for example, you have 5 pads per day, you multiply that by 5 years, we're talking about thousands and thousands of dollars that can go to just pad and diaper usage. Catheters can be very uncomfortable, whether they're indwelling or the condom catheter type. And then a penile clamp can be a good short-term solution, but like I said, most guys that come to my office are not happy with that as a long-term solution. So what are some long-term solutions that urologists like Dr. Levine and I will offer? There's 2 that I will highlight. One is a urethral sling, and the other one is a artificial urinary sphincter. So what is a sling? A sling is a small piece of mesh that's placed underneath the urethra and anchored by the pubic bones. And what it does is it compresses the urethra when there's any sort of increased intra-abdominal pressure. When there's any pressure from coughing, sneezing, laughing, it puts pressure on the urethra and holds back that urine. Patient satisfaction rate is extremely high. 95% of patients who undergo a sling would recommend this to a patient, or sorry, to a friend. So what are some of the benefits of a sling? So number one, it's not detectable to others. It is highly successful for patients with mild to moderate stress urinary incontinence. So when you come to my office, I will always grade your incontinence from grade 1 to grade 4. And those patients who are in kind of grade 1, 2, and maybe 3 are good candidates for the sling procedure. The other benefit is patients are immediately happy. Their continence is fixed, is immediate in the postoperative period, and a majority of my patients, 90 to 95%, and this is published data, would undergo the procedure again, and like I said, would recommend it to a friend. Now, the one caveat with the sling is that it tends not to be as effective in patients who've had radiation or who still have their prostate in place. So I think patient selection for the sling is very important, and we spend a lot of time going through kind of the risks and the benefits on each individual case. The sling is not kind of a one-size-fits-all, and that's where the artificial sphincter comes into place. So what is a artificial urinary sphincter, or an AUS for short? It is a cuff that goes around the urethra. There's a control pump in the scrotum, and there's a little pressure balloon that's buried underneath your muscle and your fat. And when you're walking around, that cuff is inflated, holding back urine. And then when you want to void, you press the control pump, which then transfers fluid from the cuff into the pressure regulating balloon, and then automatically refills the cuff after 45 seconds to a minute. This is really the gold standard treatment, meaning patients with grade 3, grade 4, or grade 2, and grade 2, 3, or 4 incontinence have high chances of becoming completely continent after an AUS is placed. It provides a proven and discrete bladder control. Again, there's nothing on the outside. It's completely undetectable to others. It really mimics a healthy sphincter, which closes when you're walking around and opens when you want to void. And then most men who undergo this procedure will achieve either near continence, near complete incontinence, or with the goal of complete continence. All right. So here's just a schematic of kind of what it looks like from the previous slide. And I think I also have a video. Let's see if my internet is better than Dr. Levine's. I think it is. Maybe not. Okay, so here's another schematic. You can see the pump in the scrotum next to the testicles. And when you squeeze the button, the fluid moves out of the cuff and into the pressure regulating balloon, allowing you to pee like normal. And then gradually the pressure regulating balloon will push the fluid back into the sphincter and creating a continence mechanism or an ability to hold back the urine. So what do both of these procedures look like? So both of them are outpatient procedures. They both take anywhere between 45 minutes to an hour and a half. They're done through a small incision underneath the scrotum. I'll talk quickly about the sling. So the sling is, again, a small incision underneath the scrotum, and then two small poke incisions in the groin area that's where the sling actually passes. Whereas the artificial urinary sphincter, I do mine through a small incision underneath the scrotum, and then another, what's called a counter incision, and somewhere in your lower abdomen where the pressure regulating balloon is buried. For the artificial urinary sphincter, the process is you go home, there's some discomfort for a couple of days, usually well controlled with either narcotic or non-narcotic pain medications. You avoid any strenuous activity for a couple of weeks. You come see me at 3 weeks just to see what everything looks like, make sure that everything looks good. And then at 6 weeks is when I activate the device. So you will go from the time of surgery, 6 weeks after, unfortunately continuing to leak, and then we activate the device very simply in the office by squeezing the pump, and then you're active and should be on your way to being dry. This is as opposed to the sling, which like I talked about, you're almost immediately dry after the procedure. In terms of the artificial urinary sphincter, like the inflatable penile prostheses, the satisfaction rates are through the roof. 95% of patients are satisfied with their device. 90% are satisfied with the device long-term. 90% of patients would have the surgery again, and 94% would recommend it to a friend. Now, the way that, the thing that I tell patients is the complication rates are extraordinarily low for these procedures. The patients who unfortunately do have a complication where they have a infection where the device has to be taken out, the few patients who have experienced the infection, the first question that they ask me when they come back to my office is, when can I have another one? Because even though they had the complication, they've tasted what it's like to be dry again and how they've been able to regain what they've lost through prostate procedures. In terms of insurance coverage, for incontinence procedures, I've rarely had any issues getting this covered. Medicare does a great job covering it. Commercials commercial insurances do a great job covering it. And we have members of our team at UroPartners as well, partnered with the Boston team to really fight on your behalf to get the treatment that you want. So we're able to work with insurance companies to get this covered in most cases. So in summary, what are some of the benefits to both the sling and the artificial urinary sphincter? Obviously, the goal is to achieve continence. If we can get patients down to a light pad or completely dry, then it's a win for everybody. We want some people just leak continuously. So we want patients to be able to hold their urine back and then urinate when they desire. Everything is placed inside the body. It's undetectable for others. If, again, you are walking naked on a beach, the satisfaction rates are through the roof, and it can really restore that function, like I said, that's lost. On a personal level, patients who undergo this procedure are some of my happiest patients because of how much leaking impacts their day-to-day life. And by putting in this device, whether it be the sling or the sphincter, they're really able to get back to where they were. Like all procedures, there are risks to both the artificial urinary sphincter as well as the sling. For the sling, there's the risk of just a device failure. There's a risk of urinary retention, where because of that sling, there's an inability to empty the bladder. Obviously, there's postoperative pain that's a risk. You can get irritation from the wound site, and then your body could not be happy that this foreign body is in there and kind of cause an inflammatory reaction around it, which I personally haven't seen something like that. And then infection, obviously. In terms of the artificial urinary sphincter, it is somewhat of it's a mechanical device, and so there's a chance of device malfunction or failure. There's a very small chance of erosion to the inside of the urethra, a risk of infection. Again, urinary retention meaning an inability to empty your bladder, and then pain and soreness associated with the incisions. Just to conclude, incontinence is a known side effect to prostate surgery. There's a variety of treatment options. There's treatment options for the short term, but if that leakage persists, we have long-term solutions to regain that function. You can go to fixincontinence.com to get information. We have information in our office. You can come meet with one of us or an incontinence specialist, and we can kind of start the process of getting you better. And that concludes the incontinence portion of the talk. Here are just some of the references from my talk today.